Welcome to NoseTalk. This is a podcast in association with the European Rhinologic Society, where we discuss all things rhinology related and talk to some of the world's leading experts in the field of rhinology. I'm your host, Dr. Rory, and it's my great pleasure to welcome you to our first episode. Today in this podcast, I'm going to be talking about juvenile nasopharyngeal angiofibromas, known as JNAs. Joining me on today's podcast is Mr Shawkat Abdulrahman. Shawkat is a consultant otolaryngologist in Tala University Hospital in Dublin, Ireland. Shawkat is a rhinology and facial plastics subspecialist and has completed extensive training in these areas, having trained under Professor Paolo Castelnuovo and Professor Pietro Palma in endoscopic sinus surgery, anterior skull base surgery, and also rhinoplasty and facial reconstructive surgery, respectively. I previously had the pleasure of working with Shawkat in Tala University Hospital. Shawkat is highly experienced in rhinology and anterior skull base surgery and septorhinoplasty surgery. Also joining me today is his international fellow, Mr Dhaidan Alshammari, who is an ENT consultant from Saudi Arabia, completing a rhinology fellowship here in Ireland. We're going to be talking to Shawkat about his experience of managing JNA, and we're also going to be catching up with Dhaidan about his experience of rhinology fellowship here in Ireland and some of the key considerations when choosing a rhinology fellowship. Shawkat, welcome to the podcast.
Thank you very much for hosting me, and my pleasure to be with you again.
Thanks, Shawkat. Well, let's get started. I'm going to get the ball rolling by introducing some of our listeners a bit about the background of JNAs. JNAs, first of all, are vascular, locally aggressive tumours originating from the posterior nasal cavity, typically from the sphenoid base or spinopalatine foramen. Although these are benign tumours, they can cause significant morbidity to patients in two main ways. Firstly, through growth and destruction of surrounding structures. Secondly, they have a propensity for hemorrhage and can result in significant episodes of chronic epistaxis. They typically occur in adolescent males, usually in the age range of 9 to 19, and have an estimated incidence of 1 in 150,000. Malignant transformation, however, is rare and is limited to case reports in the literature. These account for less than 0.5% of all head and neck tumours. There are a number of theories regarding their etiological development. A hormonal theory is suspected, given these nearly exclusively occur in males during puberty, but genetic and viral theories have also been postulated. So, Shawkat, these are patients that are referred to us that we see every now and again in the clinic. Tell me, what's your experience of seeing these patients when they get referred to you?
So, although you mentioned that we see it now and then, it's not that very frequent. So, as you know, this is always present in male patient, adolescent. Age of presentation usually between 8 up to maybe 19 years old. However, we face some cases beyond this age of presentation, and it's not that frequent that you can see, especially here in Europe. Is more common from Mediterranean background, especially from Egypt or from India. However, one of the cases that I done for the last couple of years here in Ireland, one was from outside Europe and the others are European.
It's interesting you say that, as certainly when you read the literature on this topic, European populations seem to report a lower incidence of this condition than Middle Eastern, Mediterranean populations, and also patients from India. It's a bit unclear at present why this is the case, but certainly interesting to note. So, Shawkat, it's interesting to sometimes see reports of JNA in females. Have you ever seen this condition present in females at all?
It's never. Always reported that there are some cases presented in women. However, always, you have to revise the histopathology.
Absolutely, I couldn't agree more. Extreme caution needs to be exercised clinically, radiologically and histopathologically when making this diagnosis in a female. So, Shawkat, how do you find these patients present?
So, usually because they are very young, sometimes these patients, they don't know how to express their symptom. So, mostly they will present with epistaxis. Then at later stage, they will complain from nasal blockage. Then they will seek a medical advice regarding repeated, extensive, unstoppable bleeding. And once you do a proper examination in your clinic, you will find there is a mass. Always link male mass bleeding. You have to put in differential diagnosis of angiofibroma.
Certainly, I know as far as when these tumours become more advanced, sometimes it can cause other symptoms such as maybe headaches or ophthalmoplegia. Have you seen that very often, or do they generally, in your experience, present earlier than that?
So usually, once the masses start to expand, it will give the headache, then the facial disfiguration. You will see like exophthalmos, or if there will be even facial asymmetry. So usually, less likely we will face it here in Europe because most of the patients, they will have an easy access to the system. But I remember during my fellowship in Italy with the Prof. Castelnuovo, we had referred cases from Arab Gulf region where they had like extensive angiofibroma that even extend to the infratemporal fossa, facial disfiguration, also exophthalmos or proptosis, let's say, to say a proper word. And even we needed to do an stage surgery because it was not controllable with the bleeding.
And I suppose we all know that main symptom is epistaxis. Do you find, for example, that sometimes this diagnosis can be missed in patients frequently presenting? Or, for example, would you do a flexible nasendoscopy on most patients coming in as first presentation?
Yeah, unfortunately, because of the COVID, hit all the globe. It's not only Europe. So we start with the virtual clinic, and usually, once you have a virtual clinic, you will ask patient about what do you have, bleeding from the nose. So you will get a general referral as epistaxis. Then, unfortunately, these will not get the priority as the sinonasal tumor or other urgent cases. So they will present lately with the mass effect. So, however, once they arrive to a tertiary center or a proper ENT clinic, we will have the proper examination, and by flexible nasal endoscope, you will see a mass. Then, never, ever do biopsy. Always I discuss that with my registrars and the fellow. Whenever you have a sinonasal mass, regardless, rule out CSF content, vascular content. Then it means that you have to do radiology, proper radiological examination. Then once you exclude both, you are free to take biopsy to confirm what you are dealing with. So don't rush. I remember one of the cases transferred here in Ireland. The other colleague, he took biopsy from the angiofibroma. However, there is, let's say, some colleagues, they don't mind taking biopsy from the angiofibroma mass. However, patients start to bleed from the biopsy side, then they refer him to me.
So, Shawkat, I think the lesson here to drive home for our listeners is that it is absolutely important to get your imaging first for considering any sort of biopsies on a nasal mass that is suspected in any way of being a JNA. That actually moves us on quite nicely, Shawkat. So, you get these patients, they come into your clinic, you've done your clinical examination, you see a mass in the nasal cavity, you think, you suspect might be a JNA. What sort of imaging would you routinely get for these patients?
So usually, let's say, the easy access one, whenever you have a nasal mass, you'll go for CT scan. Usually, unfortunately, to get an easy access, especially with kids, we don't do contrast. Although recommendation to do contrast, but sometimes it's not easy to have. This is protocol. So once you have the CT scan, you will have radiological finding, and there is radiological pathognomonic for the angiofibroma, where you will have the base of the sphenoid erosion. However, also you have the widening, you will have the Miller sign, where you will have bowing of the posterior wall of maxillary sinus, although that happened with any benign tumor. However, once you have the suggestion, you will go for an MRI in case if there is suggestion of extension through the infraorbital fissure or foramen rotundum or orbital boundary. I mean that whenever you have skull-based territories involved with the mass, you have to rule out an extension. Then, as soon as you get that, from the staging, from the size of it, although we have different staging, you will go for CT angiography, and we coordinate with your interventional radiology if it's available in your center for, let's say, evaluating the feeders.
And where do you find the main blood supply these comes from in general? Is there a particular supply or artery or anything that you find particularly?
Yeah, so usually from the terminal branch of the external carotid artery, which is what is known as the internal maxillary artery before. And however, whenever you get a larger one, you will have another feeders from the internal carotid artery through the Vedian vessels. Therefore, whenever, let's say, you're doing surgical steps, you never end your surgery without drill out the base of the sphenoid where you have the Vedian vessels and canal. So you will reduce the recurrence rate.
And I mean, there's a number of staging systems proposed for JNA. Is there any particular staging system that you use or one that you find particularly helpful?
So let's say, definitely you have to follow the different staging system that is available, but is more for, let's say, either is for us, for a surgeon, either is a big tumor that's need embolization or no embolization. Then whenever it's bigger, you will have to think that even if you do embolization, you might still have some feeders from non-embolized vessels. So the staging is very good to predict, let's say, how to what to expect during surgery, and most importantly also for research and categorizing the cases that are present to you.
Absolutely. Certainly most of the staging systems, one of the main uses is in research and I suppose classifying cases.
Most of the staging system all look similar, except the latest one from Pittsburgh group where they add a subclassification if still feeders or after the embolization or not.
So Shawkat, for our listeners out there, we're referring to the University of Pittsburgh Medical Center UPMC staging system for angiofibroma. To summarise it roughly, in stage 1, the angiofibroma is restricted to the nasal cavity or the medial pterygopalatine fossa, stage 2 to the paranasal sinuses, lateral pterygopalatine fossa, and no residual vascularity post-embolization. Stage 3 can have skull base erosion, invasion to the orbit or infratemporal fossa, and there's again no residual vascularity post-embolization. At stage 4, however, it's similar to stage 3, however at stage 4 there is residual vascularity post-embolization. Stage 5, there's gross intracranial extension and residual vascularity post-embolization. In the paper published from Pittsburgh, residual vascularity was a significant prognostic indicator as it strongly correlated with blood loss intraoperatively, requirement for multiple procedures, and residual or recurrent tumour. So Shawkat, I think that moves us nicely to management. With JNA, what are your main principles of management?
So there is like a couple of steps that you have to follow. However, you might modify it according to the extension of the disease. But as a principle, you have to have the benefit of the bimanual, binasal corridor. So personally, I say is a free 4 steps. The first step is to remove posterior septectomy. In this way, you will create a corridor for your colleague or the assistant to help you from the other side. Then the second step is to control the superior margin of the tumor. So you have to remove the partial turbinectomy, middle turbinectomy. It depends on the extension. Then now in this stage you control the superior, medial, inferior. You already have the floor. So now you have to extend laterally to control from lateral surface. Laterally you can apply the endoscopic medial maxillectomy in different way. Maybe sometime if you have very small tumor, you will be able to with very large antrostomy. Some, no, you have to remove the partial of the part of the inferior turbinate, the posterior part. And some, no, you have to extend it more laterally, removing the nasolacrimal duct and the piriform aperture.
So you're really kind of getting around this tumor and making sure you're...
The good things about this angiofibroma, it has a capsule. So you just follow the capsule and you will see the feeders that's going to the tumor itself. And you're just using the clips, and there is a critical places where you have to see what you are doing, especially when there is extension inside the sphenoid or in foramen rotundum or infraorbital fissures. In these places, you have to see. You will count on your assistant to do section retraction, and you follow the capsule. Now, because it's a very large tumor, sometimes you have to divide it at the sphenopalatine trajectory line. So you will deliver the endonasal part, then you will address the lateral extension one, which is in the pterygopalatine and infratemporal fossa.
And are there any methods you use to minimize the risk of injuring structures in, for example, the pterygopalatine fossa, the foramen rotundum, or the infraorbital fissure in these patients?
So usually in these cases, the anatomy will be distorted. So the best way to avoid injuring this structure, you have to follow the capsule, the tumor itself. However, preoperatively, you will be aware where is the critical structure. If there's involvement in the dura, or if there's involvement in the carotid arteries, or vasculars or cavernous sinus extension. Fortunately, I didn't face it here in Europe, but I think elsewhere, maybe because of medical neglectance, they will be more aggressive, more high advanced staging.
So, Shawkat, speaking of patients with advanced staging and your management of these patients, how do you know when to bring colleagues from other specialties, such as neurosurgery, for example, to help you with these cases surgically?
So there is, let's say, are you able to remove it from the dura? This is the question. So these cases will be discussed case by case because it's not that frequent will present. So you have to have an multidisciplinary team discussion. You have to discuss with the neurosurgeon, with the interventional radiologist, even with the patient. Sometimes are we allowed to leave some remnant over the dura or over the optic nerve or a critical or noble structure? Is not, let's say, in the vascular, if there is an involvement near to the carotid artery or vascular structure, there's a good possibility that you will use intervention radiology to support that artery by stenting, and you can resect the tumor. But with the dura, it's a little bit, although I discussed with a couple of colleagues about this, what's the best protocol, it will create a more problem. Sometimes it's better that you leave with remnant and keep with watchful radiological observation, and sometimes by itself it will regress. It's just because there will be no further feeders and it will turn to be just like a fibrous tissue.
That's interesting. You mentioned stenting the ICA as a means of protecting it in cases where dissection around the structure is needed. Is this something you've needed to do much before in your practice?
Yeah, there's a possibility. You know, this is, let's say, I never get such case that I'll need to do stenting. However, this case by case, discuss with MDT, with interventional radiology. You have, again, as you say, this is a benign tumor. It's not malignant, where you have to be very aggressive.
Absolutely. Yeah. I suppose it's good to have things at least in the back pocket or be aware of other techniques used for these rare cases. Yeah. So, Shawkat, a big decision when planning surgery on these patients is deciding whether to go for an endoscopic or open approach. In terms of open approaches, we have several options, including lateral rhinotomy, transpalatal, sublabial, transmaxillary, midfacial degloving, and infratemporal fossa resection. What are your main considerations when opting for either an endoscopic or an open approach?
So we return back again. This is a benign. So you have to be very, let's say, conservative as much as possible, positive as much as possible. So let's say conservative externally, aggressive locally. So I prefer will go for purely endoscopic. Even, fortunately, there is a lot of modification of endoscopic medial maxillectomy with the pre-lacrimal approach, with the extended endoscopic medial maxillectomy. In these cases, you will be able to approach all the boundary. Even if you need to do like stage surgery, because sometimes if you have extensive bleeding during surgery, it's better to stop surgery, put packing, restabilize the patient hemodynamically, then return back to patient. One of the things also is worth mentioning that, as you mentioned earlier about external approach or transpalatal approach. So some colleagues, they say, okay, we'll take shorter when you do transpalatal approach or midgloving approach or lateral rhinotomy. However, the consequences of this patient will stay in the hospital for longer than if we do it endoscopically. So, you know, here in Europe, we always like cost effectiveness about how long the patient will stay per day.
100%, yeah, couldn't agree more. I mean, it's certainly an endoscopic approach. It seems to be associated with less morbidity, shorter patient stays, which is always great to get patients out again and back to their daily living. So, Shawkat, surgery is pretty much the dominant form of treatment that we have for these patients. What is your view on the role of other treatments such as radiotherapy?
So there is possibility of using radiotherapy, but again, you have to keep in your mind this is a young patient. So there is a withdrawal about that with the long-term effect of radiation, with sarcoma, lymphoma, all these changes. Again, the critical structure that will be involved with. So if there will be with the optic nerve, which is more sensitive for radiation. So I never, never say never, but I never come across I have to go for radiation. You always, again, as we said earlier, multidisciplinary team discussion. Then you will come with suggestion that you will discuss with patient, and patient will decide which way, and you will ask, you will explain for him for the risk, cons, pros for each option, and he will decide. Or
Very fair point, in that we should actively involve patients in the decision-making process and also our colleagues from the MDT. But for our listeners, we should stress that surgery remains the mainstay and most effective form of treatment for these patients, and that the main purpose of other treatments such as radiotherapy can sometimes play a role as adjuncts.
Definitely, yeah.
My next question for you. When you read the literature on this topic, there have been some studies looking at possible roles for hormonal therapies. One of the theories is that angiofibromas can be hormonally driven. There have been some case studies looking at possible role for fluticamide, which is an anti-androgen compound. What is your view on the role of these medications in contemporary management?
As we mentioned earlier, it's very rare tumors, so we lack the number of data that we can count on it. Hopefully in the future we'll have more centralized database for such cases, so we'll exchange our experience, especially from outside Europe, and we'll take it further from there.
Absolutely, I couldn't agree more. So my next question, you've done surgery, everything's gone very well, patient's delighted. How do you perform surveillance on these patients to detect any possible future occurrences? For example, some surgeons perform MRI scans for baseline assessment and soon post-operatively. What's your view on that?
Definitely, I will ask for baseline imaging for database assessment. Then every 6 months, I will do an MRI with contrast. Then at least for 3 years. After that, less likely there will be a recurrence of the tumor.
Very good. So folks, that brings us to the end of the first part of this episode. Shawkat, I'd like to thank you for giving us an amazing overview of what is a rare but complex disease.
Thank you very much for having me here, and I hope you enjoy it.
Now I'd like to introduce Mr Dhaidan Alshammari to the podcast. Dhaidan is Mr Shawkat Abdulrahman's International Rhinology Fellow visiting from Saudi Arabia. Dhaidan, welcome.
Okay, thank you for having me today with you. It's a great opportunity to meet you in this podcast.
So, Dhaidan, first of all, tell me about your background.
I'm from Saudi Arabia. I'm the NT consultant there. I came here to doing a 2 years fellowship under umbrella of Royal College of Surgeons under supervision of Mr Shawkat in rhinology, skull base and facial plastic as well.
And Dhaidan, when you were looking at fellowships, you would have been looking at fellowships from around the world. What were the main reasons and drivers behind you choosing to come to Ireland for a fellowship in rhinology?
Yeah, of course. To have a good training, you have to look for a center that can providing you with good number of cases, different type of procedures, different type of, let's say, cases. And Tala and St. James, where I will be trained there, they have good number of cases and good different type of procedure and cases. And of course, Dr. Shawkat, he is one of the famous rhinologist and facial plastic worldwide.
Absolutely. Getting exposure to a high volume of cases and experience with managing complex cases are essential parts of a great fellowship. For example, for our listeners out there, Shawkat and Dhaidan have come down to our centre in Cork in the south of Ireland today to perform an endoscopic resection of a complex sinonasal malignancy, and it was a pleasure to have them here for the day. Anyway, thanks for coming on the podcast, Dhaidan, and best of luck with the rest of your fellowship.
Thank you.
Anyway, that brings us to the end of our first episode in the ERS Juniors podcast series. First, thanks to Shawkat and Dhaidan for joining me on today's podcast. To our listeners, thanks for tuning in, and I look forward to having you back for episode 2.